Patil University to Bhopal.
Yeah.
Three, two, one. We are live now, sir.
Good evening, all. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas, I welcome you all for this Foxy Symbiosis Series webinar 17. This is a special episode, Best of Symbiosis, episode 1. Before starting the webinar, we would like to play lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now, I would like to introduce Dr. Monica Singh. Dr. Monica Singh is consultant reproductive medicine, Bhopal Fertility and Endoscopy Center. She is Professor LL Medical College, Bhopal. She is also Managing Committee member ISA. She is West Zone Coordinator Medical Disorders Committee Foxy, as well as she is convener of ISAR Perfection Series and convener Foxy Symbiosis Series. I would like to hand over the session to Dr. Monica Singh.
Thank you so much, Dr. Vishal. And very good evening to all dignitaries, all faculties, respected Alka Kriplani ma'am, respected Dr. Atul Ganatra sir, respected Dr. Basam Mukherjee, Dr. Manoj Chilani sir, for joining in this special series of Symbiosis webinars. And this webinar is called the Best of Symbiosis. We completed 16 episodes last month, and we involved about more than 20 Foxy committees. So we found a lot of good talks in the process. Most of the talks were fantastic, but some talks were outstanding. So we wanted to give those talks again to our viewers, again to our postgraduate students and all of us. So that is why this Best of Symbiosis was formulated, and this is going to be 3 episodes. We heartily welcome our chief guest for the evening, Dr. Alka Kriplani ma'am, our guests of honor for the evening, Dr. Atul Ganatra sir and Dr. Basam Mukherjee. And before we begin the program, I would like to formally thank Foxy office bearers, President Dr. Jaideep Tang sir, who has always been instrumental in taking our academic projects forward very wholeheartedly and magnanimously. And he is there for most of the programs, but now because he's so busy, he might not be physically there, but his blessings are always with us. And I would also like to thank our Secretary General Foxy, Dr. Madhuri Patel. She is always there in all our webinars, but right now her family is visiting from abroad, so Madam excused herself. And I would now like to introduce our chief guest for the evening, Dr. Alka Kriplani, ma'am. Can I have Madam CB, please, Dr. Vishal? Dr. Alka Kriplani is the star on the sky of Indian gynecologists, and Madam is the Director and Head, Department of Gynecology, Obstetrics and ART, Paras Hospitals, Gurugram. Before that, she headed the Premium Institute of India, AIMS Delhi. Every medical graduate and postgraduate has a dream of studying in AIMS Delhi, and Madam has been the HOD there. She has held the post of President Foxy 2016, President GECI, GESI,
Okay.
continuing, President DGES, President AOGD, editor of Asian Journal of Obstetrics and Gynecological Practice, on the editorial board of 9 journals, co-chair of FIGO Menstrual Disorder Committee 2016 to 18, total of 47 awards, out of which the outstanding awards are Padma Shri for Distinguished Service in Medicine by the President of India 2015, BC Roy National Award for Eminent Medical Teacher 2007, Honorary FRCOG awarded by the Royal College in 2007, and the DMA awarded a Medical Teachers Award. Madam, we are so blessed and honored to have you. It was my dream to have you in Symbiosis, and today, finally, that dream has come true. So, Madam, we would like to have a few words from you, ma'am.
Thank you for such a lovely introduction, Dr. Monica.
and very nicely compiling it. Evening. You are very special for me because when I graduated and my post graduation from Raipur, it was Madhya Pradesh. So Bhopal, Raipur, it's like neighborhood. And I'm so happy to see both of you, Monica and Dr. Randhir is
Thank you,
your
ma'am. Thank you.
pillar of strength. So the couple performing such wonderful and for years in various societies, you both are, our stars. So I'm really very proud of you. And now I see you are also doing so well. So it's an absolute pleasure. And this is the first time I'm listening the best of Symbiosis. I think it's a great idea, Monica. Whose idea it was, I don't know. But it's a great idea that giving people the very much liked lectures, and I'll also try and listen to, because my own Jai Bhagwan Sharma is going to speak on TB, which is still an enigma and is such a big problem for infertility specialist here. And then Dr. Nitish Murjia, who doesn't know him, and that too speaking on, flouting rules from his mouth. It will be a wonderful idea. And Manish Bankar, so giving real academic inputs. So I think it's going to be giving a wonderful academic feast to your audience. And Foxy is there, but people like you and Randhir who have brought Bhopal on the national map, doing such good work in various societies. I really appreciate both of you, and I wish you grand success for this best of symbiosis. Thank
Thank
you.
you. Thank
Thank
you.
you, ma'am.
Thank you so much, Alka ma'am. It is always very encouraging and it, lights a fire inside us when we see you, You are such a radiant and brilliant personality, ma'am. Always positive. Thank you so much
Thank
for
you.
being here, ma'am, blessing the program. And I'm sure if you stay on for the program, you will really find that these talks have been handpicked. The speakers have been
Sure, sure.
handpicked.
Thank
Thank
you.
you. Thank you so much. Now it is my proud privilege to introduce our guests of honor for the evening, who have been very, very large-hearted for being here despite their busy schedule. And with one invitation, they said yes. I would like to introduce before you Dr. Atul Ganatra, sir, who is President, Indian Association of Gynecological Endoscopists, year 24 to 25. Sir has been Vice President of Foxy 2021 and member of the Managing Council MOGS. Sir is also VP of IMO Mullen and consulting obstetrician gynecologist and gynecological endoscopist at Fortis Hospitals and Jupiter Hospital, Director Ganatra Nursing Home, and Director Progeny IVF Center. We are honored to have you amongst us, Dr. Ganatra, sir, and we would like to have your words for the program, sir.
Thank you, Dr. Monica. I think I echo Dr. Alka Kriplani's sentences, and I think it's going to be a very interesting webinar. Congratulations and all the best. I don't think I should take away more time of the delegates. We wish you the very, very best.
Thank you. Thank you, sir. And we have seen you taking over in Varanasi. I was there for the annual IAG conference. I'm sure IAG is one society where I think MP representation is a little lacking. I would like that MP should, involve more and more youngsters should, take up endoscopy as their passion. And under teachers like you, take the state forward and of course, take India forward. Now, I
Thank
would
you.
like to introduce, thank you so much for being here, sir. I would like to introduce now Dr. Basav Mukherjee. Sir has to leave for an RCOG meeting very soon. So we would like to welcome him thoroughly. I have seen him in Vision very recently in Kolkata. We know how dynamic he is, how much, such a great academician, such a great speaker. And sir's organizational role has been as organizing secretary in all these great conferences which people vouch for till now. We know FORCE 2010, UFOXY 2012, Endogyne 15 and 17, BoxCon 18, and of course the very, very meticulously planned AICOG 2023, which set benchmark. Very few can, match those standards of AICOG, which was held in Kolkata Kolkata just recently. Sir is Vice President Foxy 22 to 23, FIGO Regional Coordinator for Safe Abortion 17 to 23, Secretary of IRC India East, he's already now President Bengal OBGY Society. We congratulate Sir. Vice President Kolkata Menopause Society and Secretary IAGE Bengal chapter with several awards and achievements like Yuva Foxy Orator, AOFOG Young Gynecologist, DC Datta Best Publication Award, Appreciation Awards from Rotary, and as Secretary BOGS, he won 4 Foxy National Awards, including the Pride of Foxy 2021. He is the TRG member, Family Planning, Ministry of Health and Family Welfare, Government of India, and also a reputed clinical examiner for MRCOG Part 3. Asap sir, we are very, very privileged to have you amongst us. And please, we are waiting for your address for us and for our audience.
You're
Sir-
muted, Basap.
Thank you. Thank you, Atul. Thank you. So nice to see you. Thank you, Monica ji. Thank you, Ranjit ji. Thank you, everybody. It's a pleasure being here. It's we're hopping from webinar to webinar, and this is a wonderful place to be. So good, nice to connect with everybody. Wonderful program. Congratulations, Dr. Monica, on your Symbiosis, which is reaching webinar 17. So that I think the consistency is so important. The very fact that you're doing and continually doing this academic program is good and it's nice. That's something which needs definitely a lot of effort, and we congratulate you for the same. You have Dr. Alka as our chief guest. She's a lady who we always look up to, and that's something she's very special. Atul is here, one of my dear friends. Atul is, it's wonderful that Atul is here, and we can connect at least virtually till we can meet physically. And you have speakers like JB talking on TB, Dr. Manish Bankar talking on infertility, Dr. Nitish Murthy talking on ART. I think you've got some of the really classic things, and you kept the program simple and short. I think that's so important, not to add too many people and too many speakers. 3 talks make it nice and quaint, and I think that gets a lot of takers. So in the time when we have physical programs and webinar programs, it's so important to get your audience and to make sure that you are pertinent and keep things short and succinct. And I think you've done that, Dr. Monica. I congratulate you and wish you all the best for your Foxy endeavors, and hope everything counts and all the hard work that you've done does make a difference and people take notice of that. Thank you very much, and all the best.
Thank you. Thank you so much.
Thank you, sir. Thank you, sir.
Those are very, very nice words. And of course, our endeavor was to keep the program, within limits. And every speaker of that repute, once they reach the stature of Manish Bankar sir or JB Sharma sir, we can't give them a talk of.
They don't overshoot, and they do full
Yes.
justice to your session. I think it's so important. You get your audience straight, because once you have a people like this, your audience will come naturally. It's just a matter of getting it.
So 30 minutes sounded a very nice time, and we can even go to 35, 40 minutes. Our studio people are extremely, extremely, cooperative, including Dr. Vishal over there, who has been with us for almost 2 years now. So without wasting time, I think Dr. Neetu, I would now like to introduce our BOGS, just take a minute to introduce our BOGS office bearers. Dr. Neetu, could you do the honors? Because we are doing this as a program with Bhopal Obsgynae Society.
Thank you so much, ma'am. It's my privilege to introduce our office bearers of Bhopal OBGYN Society. We have a very dynamic president, Dr. Anita Srivastav, ma'am, and due to some, she is traveling now. She could not join, but she will join shortly in this webinar. She is president of our society and has been the organizing chairperson of the very successful VPCon Bhopal, which held just in the month of July. And as a dynamic secretary of our society, Bhopal OBGYN Society, we have Dr. Shabana Sultan ma'am. She is with us. She is head and professor, Department of OBGYN. She has presented many papers in national conferences and has many papers in national and international journals. She is member of Esteem PPH Bundle, which was done along with Sevagram and Howard University. She is very dynamic in academic our academic front in Gandhi Medical College. She has special area of interest in gynae oncology and high risk pregnancy, and she has also been the organizing secretary of very successful Bhopal VPCon. We welcome you, ma'am, and want to hear something from you about this
Thank you,
special
Neetu.
edition of Symbiosis.
Good evening, everyone. It's my proud privilege to be a part of Symbiosis series, which is really very wonderfully organized by elder sister. And I really congratulate her for choosing so many special and best speakers with so many combination of good topics. And I think this is the best part of this best Symbiosis series. And thank you so much for making me a part of this. And I really wishes her lots of many success for her future election of chairperson. Thank you so much.
Thank you, Shabana. Thank you for joining and thank you for the nice words. Neetu,
Thank you, ma'am. Now we will have CVs of our convener and coordinators of
Yes.
this Symbiosis webinar.
I'll just pay my thanks to my co-convener, Dr. Randir Singh, who is always the support behind me, besides me, always 24/7. Let's go to our coordinators who are doing very, very dashing work. So I would like to acknowledge the hard work and pains put in by Dr. Neetu Mishra, who's Associate Professor in the Department of OBGY at AIIMS Bhopal. AIIMS Bhopal is very soon going to have an IVF center of its own, which is going to be a landmark, in the healthcare sector of Bhopal. Can I have her CV, please, Vishal? As we can see, she is a great academician from Odisha. She has done her UG and PG studies there, then joined AIIMS Bhopal, winner of quizzes Ekambra Meet, has written an original paper on the role of HSCRP, C-reactive protein, as a marker of severity in preeclampsia, and also teaches PhD students in AIIMS Bhopal. She has had more than 20 publications, which I came to know from her in papers as well as book chapters. Thank you, Neetu, for you always helping me out with Symbiosis. Next, I would like to introduce two more very, very sweet coordinators of mine, Dr. Purva Patkur. She just had a baby, but she's still very, very hardworking. She did the entire scientific program for VPCon along with Dr. Shabana, which was a great success. She is an assistant professor in one of the most busy government hospitals of MP, that is Gandhi Medical College, Bhopal. She's very much interested in colposcopy, high-risk obstetrics, has done several research papers and written chapters, won prizes, and recently delivered an oration in our state conference. Welcome, Purva, and thank you so much.
Thank you so much, ma'am, for your kind words.
I'd like to acknowledge another, dynamic coordinator, Dr. Nandini Singh Bhati, who is again assistant professor in the Department of OBGY and GMC. She has interest in high-risk obstetrics, antenatal and gynecological ultrasound, reproductive medicine, and gynecological malignancies. Again, a very, very hardworking individual. Thank you, Nandini, for everything. And now, without wasting time, Dr. J.B.
Thank you, ma'am.
Sir has joined. Let us start our first session, which everyone is waiting for.
Now finally the wait for this best of Symbiosis episode 1 is over. We will move forward to our scientific session. For the first session, we have speaker none other than Professor Dr. J.B. Sharma sir. He is professor at OBGYN department, AIIMS New Delhi. He will be talking on current evidence-based guideline for the diagnosis and management of female genital tuberculosis. To chair this session, we have two very eminent faculties, Dr. Manoj Chelani sir. He is chairperson MDIP committee FOXY, and Dr. Aarti Nimkar ma'am. She is president Pune OBGYN Society. Dr. Manoj Chelani sir is director at Ayush Hospital and Test Tube Baby Center, Raipur. He has been active in various positions at ISAR. He is also the chairperson of CG ISAR from 23 to 25, scientific chairperson National ISAR Embryology Conference, chairperson of Medical Disorder and Pregnancy Committee FOXY. He is also served as president in past in Raipur OBGYN Society, organized many conferences, and has awarded by Chief Minister of Chhattisgarh. We
Thank you.
welcome
Thank
you,
you, Dr.
sir,
Nitya.
and
Thank you.
looking forward for a great input from you, sir. Our second chairperson, Dr. Aarti Nimkar ma'am, she has probably not joined because of some commitment. I request Dr. Monica Singh ma'am to chair this session in place of Dr. Aarti Nimkar ma'am. And I hand over the session to our chairperson to carry forward the session and introduce our speaker, Dr. J.B. Sharma, sir.
Dr. Manoj, please.
Yeah. So good evening, everyone. It's really an honor to chair the session of Dr. J.B. Sharma, sir, who I really admire. And I was in his committee of Urogenic in Foxy before taking over as chairperson Medical Disorder and Pregnancy Committee Foxy. So he's currently working as professor in AIMS, and he's an ex-professor of Maulana Azad Medical College, and he's worked at St. Bartholomew's Hospital in USA. UK for 4 years. He was awarded by Dr. B.C. Roy Award by Honorable President of India in 2015 for research in OBGY. And he has more than 350 publications. He is author of many, many books. And he has edited 2 books and written 5 chapters in John Studd's Progress in Obs and Gynae, published for UK. And he is editor-in-chief of OBGY Today and is presently the chief editor of Indian Obstetrics and Gynecology, Journal of Pediatrics, Obstetrics and Gynecology, that is JPOG. And he has won Indian Council of Medical Research Amrit Modi Unichem Prize for his research work on anemia during pregnancy. And he had Best Paper Award in 2003 on role of lycopene in prevention of preeclampsia. So, sir, we are looking forward to the wonderful talk on genital tuberculosis in females, which we see that is so common still, like we are struggling with that. So, welcome, sir.
Thank you. Manoj is my brother, and like I'm so happy that you are doing so well. And I'm thankful to Dr. Monica Singh and wish her all the best for our upcoming election. And respected chairperson, so it's a pleasure to be here on this podium with the dear Manoj and other chairpersons. So my topic today is basically female genital tuberculosis. I mean, evidence-based, and so we all know that tuberculosis is a major public health problem. That what means pulmonary TB and others. Next slide, please. And we all know what are the various risk factors also for tuberculosis. And the first case of genital tuberculosis was described by Morgagni as early as in 1700 something on a dying adolescent girl. Next slide, please. But Robert Koch discovered tubercle bacillus in 1884. So exact incidence, I mean, that is about pulmonary TB. But we have to be concerned about female genital tuberculosis, which is often ignored by our program and TEP and other program directors. They feel that they give more stress to actually pulmonary TB because that is a contagious disease to others. So we have to fight with them many times that to give treatment for FDTB. So it is underreported because of asymptomatic cases and lack of reliable confirmatory signs. But it may be seen in up to 30% of sputum positive pulmonary TB patient. I mean, Dr. S.N. Tripathi many years back did study. They did laparoscopy on all patients of pulmonary TB patient and found almost 30% cases had concomitant genital TB. So typically, it's a disease of young women. In developed countries like Scotland, etc., or Europe, is 40 years. So, but in India, it is about 20 to 40 years. That means average median is 30 years, and that is the time when ladies try to conceive. The prevalence is generally 10%, but we found it much higher in AIMS because of the patients referred from other areas, like from we get patients from Bihar, Uttar Pradesh, etc. That's why we find it right. And almost 8% of AUB patients also have FGTB. So that's why I always ask my residents that always for AUB patients, we need to do endometrial sampling to rule out tuberculosis. So we know that Mycobacterium tuberculosis is the causative organism for most of the FGTB, but rarely Mycobacterium bovis, especially on consumption of unpasteurized milk. Then rarely Africum microti, atypical Mycobacteria can also participate, but mostly it is MTB. Yeah, next please. So normally, I mean, grossly, if we talk about FGTB, it is secondary FGTB, but rarely 1 to 2% it can be primary genital TB when from a infected male partner with AFB in the semen. So that can be implanted in the woman, and that can cause actually the cervical tuberculosis, vulval and vaginal tuberculosis through the infected semen. It is very, very rare, but it is possible. Next piece, so mostly, I mean, the tuberculosis is usually secondary genital TB, and in that case, it's the commonest is pulmonary TB. So from pulmonary TB patient through hematogenous route, it spreads to the fallopian tube and uterus, or other extrapulmonary TB like GI tract being very close proximity to the uterus, and also they can catch from that also, or renal tuberculosis, skeletal, meningeal, miliary. So it is important that when we get a case of FGTB, we have to find out the primary at any of these sites. The commonest spread is hematogenous route, and lungs are the most common site. And usually the fallopian tubes, because they're very rich vascular supply, that is the most favorable notice. And unfortunately, that disease spread to both fallopian tubes. So, and then on the mucosal layer outside also. And there is a tendency for bilateral involvement and subsequent dissemination to other genital organs and peritoneum. The rarely lymphatic spread can also cause, especially from primary abdominal, and direct spread from neighboring viscous, like, right fallopian tube is very close to the ileocecal region, which is a common site of ileocecal tuberculosis, the commonest site of GI tuberculosis. So from there also, the infection can reach similarly from bladder and rectum also. So that is important, yeah. So that is infection spread. Now the sites involved are almost fallopian tubes are involved both in almost 95 to 100% cases. Uterine endometrium in about 50 to 80%. So in other words, 100% tubes, 70% uterus. So these 30% patients are those who will be suitable for IVF-AT. Ovaries in about 20% cases, cervix 5 to 10% cases, uterine myometrium, and vagina vulva rare. So commonest is fallopian tube basically. Yeah. So, and these are we have already done that. So the risk factors for pulmonary TB, they will be true for, because mostly our genital infection is from pulmonary and other TB. So those poverty, malnutrition, overcrowding, diabetes, etc., they will be HIV infection. They will be risk factors for genital TB also. But having said that, even rich patients can have it. So this is the most common, I mean, otherwise tuberculosis is the commonest cause of death. We are not discussing that, but it's important cause of morbidity. May not cause genital TB doesn't kill the patient, but it causes a lot of morbidity, infertility, dyspareunia, menstrual dysfunction, chronic pelvic pain, and PID, chronic PID, etc. And many times non-specific symptoms are there, and chronic and cryptic clinical manifestation can be there. Yeah. Next, yeah. So usually, I mean, it is, I already discussed that it's spread from the pulmonary tuberculosis, and may also spread from other like lymph node TB and abdominal TB also. Yeah. Next, please. Okay. Okay. So what is very important is, like, whenever we talk about pulmonary TB or other types of TB, they usually invariably they have symptomatic. But up to 10 to 12% patients of genital TB may be asymptomatic, and even if the symptoms are there, they're very subtle sign. Like patient will not have high grade fever; it may be just 99 to 100 degree, and some slight loss of appetite. You will find it then very little bit thinner side girls and all look wise, they look normal, but slight weight loss, slight loss of appetite, and poor general condition may be there. Menstrual dysfunction, initially the tuberculosis will cause ulcerated lesions on the endometrium. So at that time, patient will have menorrhagia, postmenopausal bleeding, or perimenopausal bleeding, or like AUB. But later on, the tuberculosis will eat away the endometrium. So patient will have oligomenorrhea, hypomenorrhea, and amenorrhea. Amenorrhea can be because of it can be like it can be even primary amenorrhea, sometimes or secondary amenorrhea, usually secondary amenorrhea. And sometimes amenorrhea may be apart from involvement of genital tract, amenorrhea can be there, because of an antigonadotrophic effect of the TB toxins. Then most patients will have either primary or secondary tuberculosis, infertility. Mass in abdomen usually we tend to be more of vague. Then abdominal pain, chronic pelvic pain, acute abdomen, and abdominal giant discharge is also fairly common. Next please, yeah. So same way, the sign now up to 10 to 12% patient may have no sign. So it is important that 10 to 12% patient have no symptom, no sign. They look like normal, which is unlike in pulmonary TB. But some patient may have like little bit of fever, lymphadenopathy, crepitation on the chest, or other evidence of skeletal TB, lymph node TB. So that's why it's very, very important when we examine these patients, we have to thoroughly examine the patient from head to toe to find any evidence of TB at any other site, which is easier to to take sample from. I had a girl who had Tibo-Orient mass, and then we were unmarried girl, so I was thinking what to do, how to take a sample, and then we saw a discharging sign in her knee. Another girl, unmarried girl, TO mass, and the differential diagnosis is from germ cell tumor, but it looked like vague mass, and also when we examined her, there was a lymph node in her neck. So from that we took FNAC. So that's important to examine these patients. And abdominal examination for mass, abdominal ascites, doughy feel. Then vaginal examination for uterine enlargement, which could be because of pyometra or secondary infection also. And abdominal, mass is vague or definite. Similarly, tubo-ovarian mass, vago, definite fullness and tenderness in the pouch of Douglas. And rarely, I mean, the involvement of cervix, vagina, vulva can cause ulcerative or hypertrophic lesion, which may masquerade like carcinoma. And we can take biopsy from there. And I even saw a patient of psychogyral fistula, rectogyral fistula in girl. And when I took biopsy, there was no history of sexual trauma. So when I took biopsy, it looked funny to me. So I took biopsy and it grew TB bacilli. So I gave her ATT, thinking that I'll operate her later on for fistula repair. And have a guess, after giving 6 months therapy, the fistula had healed itself. So whenever you have any tuberculosis causing this thing, better to treat it with the ATT and then only think of surgery. Many times they may not require. Next slide, please. So now that a test will, so how to suspect the diagnosis. So single most important factor is like, keep high index of suspicion as we talked in other conditions. So any family history of tuberculosis or history of ATT in the past or history of TB in a close family member or past history of TB is very, very crucial. This I want to highlight again because, these when we see these patients, they are coming to us with infertility. And now this lady had maybe at the age of 10 years, 15 years, she had pulmonary TB. And this fact has not been disclosed to the would-be groom. Otherwise, they will be difficult in getting her married. So many times they don't disclose this history. So that's why it's important to talk the patient in confidence that I'll not disclose, your past history to your husband or your in-laws. So, but tell us. And then many times the patient, 30% will give past history of pulmonary TB, and on this pretext that we don't disclose it to them. Similarly, there is a concept in North India, like, whenever elderly, like father dies of TB, so usually the adolescent girls look after their dying father, grandfather, etc. And they may catch infection from them in pulmonary TB. So that's why history is very, very crucial. And then general physical examination, I told any lymphadenopathy, you can get easily FNAC from there. Similarly, bone joint size, I told you in that case, there was discharging sinus. Then chest examination, even past history of past lesions on X-ray can be seen. And really, like my wife is a pediatrician, TB expert. So this is, we can even test to be done is endometrial aspirator biopsy. Usually we tend to do day 21 to 24, and in that cycle patient keeps abstinence, so that we don't disturb the pregnancy. We divide the sample in 2 or 3 parts, and one sample with protein saline, we send it for AFB microscopy by ZN stain or other method, whatever you do. AFB culture by MGIT or BETTEC, gene expert. These we are doing, and PCR also we are doing it, but LAMP and LPA, they are just like in research settings. And then one part we send in formalin for histopath examination. So if the patient has any like AFB microscopy positive, she definitely TB start treatment. If she has got histopath AF positive again, but PCR positive then may not be definite. And on histopath, definitely you may not get actually typical epithelioid granuloma because there is no time for that formation. Every month patient sheds endometrium. So even so it's important to take confidence. I always send my sample to one pathologist who has special interest in tuberculosis, and he can even pick up like epithelial destruction, dilatation of gland, inflammatory exudate in that, and that can, or even instead of proper granuloma, they can show granulomatous endometritis. That also is in favor of tuberculosis, because typical cage-18 granuloma may not be visible because every month patient sheds it. Okay. So that is, and almost it may detect PCR. PCR is a good test, but only thing false positivity may be high. It can detect in less than 10 picogram of microbacterial DNA, and we can do the sensitivity and specificity are high. But some National Tuberculosis Elimination Program doesn't allow us to start ATT only on the basis of PCR. But what I do that I use the PCR as a method of screening. Like those patients who have got AFB positive, AFB microscopy culture, or histopath positive, or gene expert positive, then they are definitely TB, no need of further treatment. But only PCR positive, then I do laparoscopy and histoscopy on these patients. So you can use PCR as a method of screening to do laparoscopy, histoscopy, because most patients, we are using the term composite reference standard these days, which takes a combination of various factors like AFB microscopy, culture, gene expert, and then PCR, and then ultrasound finding, then laparoscopy and histoscopy, so that we use the term composite reference standard. So this is again the total of the PCR, gene expert. Rarely we can do radiological modalities are not very, very useful unless there is tubo-orient mass. And then again here Dr. Ashok Khurana in Delhi, he can pick up early cases of like tuberculosis on ultrasound scan. So it's important that the person who has special area of interest in that can pick up, early signs. HSG normally we avoid in case of suspected TB because it can flare up the disease. But many times patients had actually laparoscopy done, HSG done outside for infertility without suspicion of TB. So then we get the pictures of that. CCT, MRI, PET, rarely we do, only if there are tubular masses, but only thing you can do only one test. And endoscopy, of course, is important whenever like we are suspecting tuberculosis or like patient have oligomenorrhea, hypomenorrhea, infertility, thin patient or positive Mentox test or like, positive PCR or some slight tumor mass, etc. Then we can do do endoscopy on these patients. So we use this method as screening tool. But the patient has got a definite test positive like gene expert positive or histopath positive or AP microscopy culture positive, then there is no need to go further. We can start treatment only on that basis. But endoscopy definitely useful. Next slide, please. So so this is the gene expert. We published a study in European journal. It has the gene expert has sensitivity of about 30%, but specificity of almost 100%. So, but still again, it misses 70% cases. That is the drawback of most of the tests. AB microscopy culture, they come positive in less than 5% cases of genital TB. Next slide, please. So radiology, I told you, has role only in TB-orient masses, and any of these tests can be done. Yeah. Next slide is okay. Next slide, please. So this is the So you can see that the mass is very vague and not well defined unless it's in case of like serous cyst adenoma, mucinous cyst adenoma, germ cell tumor, you'll get a clear cut mass. You can get septa, you can that. But in case of tuberculosis, it will be a vague mass like in this case. But again, this is not definite of tuberculosis, but in totality, like this patient had positive PCR, this person, and then we did laparoscopy also on her, and we found the TB-orient mass, and we presumed it to be TB and gave her treatment. Next slide, please. So similarly, the CT scan again can show us the enlarged lymph node with cageation inside, and sometimes the TB-orient abscess can also be seen. Next slide, please. And MRI also. This is the MRI picture. You can see the cageating masses there on both sides, and with the collection of pus-like structure, pus-like thing in that. So this is the MRI can also pick up the patients and can differentiate between ovarian malignancy and tuberculosis, but not very, very specific. Next slide, please. PET-CT, no, PET-CT is a useful modality, but little bit more expensive. But we use it like if the patient has a TO mass, and then there is increased glucose uptake, especially unmarried girls, where you can't do endometrial sampling. And also, if the patient has got like ascites, lymphadenopathy or not, so I tend to do a PET-CT on them. And if there is increased glucose uptake, that goes in favor of in favor of tuberculosis. In case of malignancy, the increased glucose uptake is very high. In case of tuberculosis, is moderate, and in normal patient, it is less. So that is how Dr. Rakesh Kumar, our nuclear medicine expert, he can differentiate. Of course, it is not 100% reliable, but we can use it in unmarried girls where sample taking is difficult. Another use, I am using PET-CT as an endpoint. Basically, like suppose patient had abdominopelvic TB, I gave her ATT. After 6 months, I repeat the PET-CT. If on PET-CT mass has disappeared, there is no glucose uptake, then patient has healed. If not, then we can increase the extend the ATT for another 3 months or so. One of my patients required for 12 months and even 15 months. Usually 6 to 9 months is good enough. And my colleague, Dr. Ravi Mittal in orthopedics, he uses it in skeletal TB like after 12 months, 15 months, 18 months. So some patient may require a little longer. Yeah, next to it, that's fine. So it can be used as an endpoint also. Now, laparoscopy, HSC, they are complementary to each other. I can combine the two. But when we are doing laparoscopy, then there is no need to do HSG. And suspected case, you avoid HSG. Next slide, please. Yeah. So this is, okay. So these are the we did publish study on HSG finding of in tuberculosis. Next slide, please. So we can get many signs like this. You can say BD tubes is there, blocked tubes is there, fibril end, or sometimes shrunken cavity can be there. Next slide, please. So these are the various finding on HSG, but normally in suspected patients, this is totally shrunken cavity, you can say, and both fallopian tubes were very calcified. Next slide, please. Then, so again, very T-shaped cavity, small shrunken cavity, and the dye blocked femoral end on both sides, dye going into the lymphatics on the one left side. Next slide, please. So those HSG can see. So laparoscopy is the single most important reliable tool to diagnose FGTB, especially for tubal, ovarian, and peritoneal disease. So whenever I suspect it, and in any case, in case of infertility, we have to do a tubal patency test. So better instead of doing HSG, let's do laparoscopy, hysteroscopy, and we can have a direct visualization of the whole cavity, whole abdomen. I have a look. So what do I put? A rotated degree starting from the right, liver, gallbladder, and all over the abdomen. So there can be tubercles on peritoneum, ovary, cages, nodules, tuberine mass, hydrocephalus, tubal blockage, adhesion, abdominal, pelvic, perihepatic, and incision ascites. So there can be definite sign of TB, FGTB, which are tubercles, cages, nodules, and BD tube. These are the three definite signs on which we can start. Others are like probable signs. So what we do, I'm trying to develop an algorithm, but still like it will take some time. So what we mean to say that if the patient has got like many, not single sign, but many 2 or 3, so then that becomes a probable genital TB and you can start treatment. So our NTP program, they refuse to start treatment. So what you can write laparoscopic evidence of male genital tuberculosis, then and you put your signature stamp, then they have to give it to the patient. So yeah, next slide please. So I will be just showing some slides on. And we collected data of over 24 patients from A and MAMC Lady Harding GTB hospital, where we opened the abdomen for ovarian cancer and it turned out to be tuberculosis. So if you open the patient for tuberculosis and point that I have to now remove this tube and ovary or uterus, just come out, take biopsy, come out, give it to the patient. She may not require surgery because doing surgery will be very difficult. Hysterectomy will be very difficult. There is risk of bowel injury, bladder injury, uterine injury. So avoid surgery unless absolutely indicated. Yeah. So these were the study we did on some patients. Yeah, next please. 374 cases. Just quickly you can show. Yeah. So this So now this is the patient. She had positive PCR and you can say inflamed tube. But this inflamed tube can be in chlamydia or mycoplasma also. But this patient was infertility. She had positive Mantox test, slightly raised ESR, and oligomenorrhea. Infertility, PCR was positive. So when we did laparoscopy, we found is like inflamed tube. So we took it as a probable TB, not definite, and we gave her ATT. Next slide, please. Okay, so this now in this case, that's the importance of showing all of the abdominal cavity. You can say the cages nodules on the omentum and the peritoneal cavity. So, and this was almost like a frozen pelvis. TB is a case, important cause of frozen pelvis in India. Apart from, like I see in my practice, 33% are malignancy, 33% endometriosis, almost 30-35% in India are because of tuberculosis also. So this is a very definite case of TB. Next slide, please. Yeah, again, so various type of adhesions are fairly common. And they can be perihepatic adhesion, almost 48% patient. So I want to highlight that whenever you are doing laparoscopy, rotate 360 degree, look all around. And but avoid doing too much of in the first stage. I don't do adhesiolysis because they tend to bleed more. So what I do, I give, if I diagnose TB, then I give them ATT for 6 months. And in second sitting, after 6 months, I do like histoscopic adhesiolysis or laparoscopic adhesiolysis. But minor adhesions can be removed. Yeah. So next slide. Okay, adhesions are there in this case. So that is important. Next slide, please. Okay. So this is important. Now this patient had very calcified tubes, on both sides. So this will have poor prognosis for fertility. Next slide, please. So these are the quickly if you can slide the again cages nodule on the omentum. Next slide, please. You can quickly pass on the slide. In this case, there is a cages nodule in the pouch of Douglas, very specific of TB. Right tube is blocked and hydrosalpinx is there. Next slide, please. Again, this case had concomitant endometriosis and TB both and frozen pelvis. Next slide, please. You can quickly pass on the slide. Again, angry looking uterus tube ovary, but this was suspicious of TB. This can be seen in other conditions also, like mycoplasma, gonorrhea, etc. Again, the tubal patency test after it was positive, but this patient before had hydrosalpinx. Next slide, please. So quickly, if you can show the slide, convoluted tubes again, not diagnostic of TB, cages, nodules, and sorry, these are the tubercles on the uterus, saggy looking. This is quite specific of TB. Next, please. If you can quickly pass on the slide. This is the hanging gallbladder sign. Again, hanging gallbladder sign. Next, please. So that can also be seen in TB. In this case, I found the blue python sign. When you inject dye, then the tube gets swollen. It looks like a blue python. Later on, dye trickles also. So dye doesn't flow. It comes slowly. So that goes in favor of TB. In this patient, you can see cages nodule very definite of TB, and they're both fallopian tube got fused to each other. So kissing fallopian tube sign, just like we have kissing ovaries in case of endometriosis. Next, please. In this case, ascending colonic adhesion at lower two-third, upper third junction. Next, please. So that also can be seen in TB. And then you can do next, please. We have already done that. Next slide. Okay. Again, next. Adhesion yeah, this is the importance of seeing all around. This patient had cirrhosis, which is not TB, but that is the importance of seeing all around. And then I referred the patient to hepatologist for proper treatment. It was not TB case. Next, please. Okay, so then I saw this patient of shrunken cavity, and both tubes were very much like shrunken and all. So it was like right tree branch sign that also is seen in TB. Next, please. And the same patient, when I did laparoscopy, you can see it can be unilateral or bilateral. The tubes were totally shrunken, and you can see the calcified tubes are there. So prognosis for fertility is going to be poor for this patient. Next slide, please. Okay, so next page again. So there can be like parachute sign, ascending colon gets adherent to the anti-abdominal wall. So this has relevance, Dr. Manoj, that when we put the second port, we can go through the ascending colon. So avoid putting the second port on the right side, or put it only under vision. On the left side, like descending colon, sigmoid colon are less commonly adherent, so we can put the second port on the left side to avoid injury. Next slide, please. And the same patient in high power, you can see the cages nodules on the ascending colon and the mesentery of that. So that is importance of this. Next, please. So then I also saw the sigmoid colonic adhesion in some of these patients. You can see this sigmoid colonic adhesion band is there. Descending colon is not involved, but sigmoid colon can be involved because it's very close to the pelvic area. Next, please. Again, there can be like compartment like sign, different type of adhesion. Next, please. Quickly, if you can. So yeah, again, these are the compartment signs, just like we see in pyogenic infection. So nature tries to control the disease in one corner of the abdomen. Next, please. Yeah. Okay. So then next, please. Yeah, TB algorithm. I just want to. I'm about to finish in 2-3 minutes. Next, please. Okay. Yeah. Next slide. So basically, what is important is okay. This is the case, Doctor. Go back to the previous slide. So there was this large cages nodule I found. This patient is I mean, you can see the uterus, and this was 5 centimeter. I have never seen anything like that. So I gave it a sign like a cotton ball sign. And this patient, I know this patient from a very rich family. She had pulmonary TB in the past, so we gave her ATT for 6 months. I referred her for IVF. She had IVF, and 3 months back she rang me, that they are doing cesarean on me. She had a baby girl. So can you believe, after such a thing where tubes were not even visible, and this patient after ATT of her own IVF, she conceived and had a baby girl now. Next slide, please. Yeah. So this is okay. So this histoscopy also can show adhesions and as band pale cavity, and so this can be. Next, please. You can. Again, so grade 3 to 4 adhesions can be there. Next, please. Again, adhesions, great. Yeah. So the different grades of adhesion in non-histoscopy can be seen. Pale cavity, nodules, cages, nodules, or tubercle can be seen non-histoscopy. Next slide, please. Again, so these are the types of like various adhesive bands on the histoscopy, cages, nodules, or tubercles. They can be seen. Next slide, please. Okay. Again, so these are on ultrasound scan. We have already done that. Next, please. Okay. Yeah. Gene expert study, we have already done that. Next, please. So I just want to go on the treatment. Yeah. Yeah. Okay. Carry on. Yeah. Keep on passing. Yeah. But there are increased complication in these patients. So treatment has to be, it should be done by senior expert person. Otherwise, complication rate are higher. And now you can report the case. I refer the patient to DOT center. So please take help of the government setup, and that you can refer the patient to DOT center. Even for private hospital doctors, they are giving free treatment. They are diagnosing the patient. Patient get 500 rupees per month per portion also, apart from free medication. So grossly, we are giving RHZD for next please. So all patients will get, again. So National Tuberculosis Elimination Program or WHO both give. Next, please. I want to show the treatment. Yeah. So So the grossly, what I want to highlight is only that patient is given RHZD, rifampicin, isoniazid, ethambutol, pyrazinamide daily for first 2 months. Then RHE. In old days, we used to give only 2 drugs, RH, and we used to give RHZD alternate day. No. Now RHZD daily for 2 months. Then RHE 3 drugs, rifampicin, isoniazid, ethambutol. Don't stop pyrazinamide. So that we give for next 4 months. So that is the treatment we are giving for all patients. And what I do that next, please. This is the drug sensitive TB. Most of them are there. Drug resistant TB can be rarely there. Then don't treat these patients. Refer them to the experts. Next, please. Then the treatment may be 18 to 24 months. I won't go into detail of that. So if the patient, normally patient can take from DOTS free of cost, but otherwise you can prescribe, like, drugs are available from market, CX5 or AKT4. So AKT4 daily for 2 months, AKT3 daily for next 4 months. Similarly, CX5 daily for 2 months or CX3 daily for next 4 months you can give. That is from the market you can buy. Next, please. And at the end of the therapy, what I do monitoring is, I mean, usually most patients tolerate ATT safely, but sometimes they can be hepatotoxicity, liver enzyme get derailed. Then you can stop the medicine for some time and gradually give one medicine after another, and most patients will be able to tolerate them. But we don't count that 1 month. So you have to give treatment for 7 months, so instead of 6 months. And sometimes pyridoxine can be given in this thing. So normally after giving ATT, surgical treatment usually only when there are abscesses you can drain them, otherwise avoid surgical treatment. Next, please. Now most patient, this is the patient I operated and for CA ovary, but it turned out to, you can see the cages material coming out and everything is so frozen. So I just came out, took biopsy and gave her ATT. So didn't try to do this thing. And after, so after what I do, Dr. Manoj, basically after 6 months of therapy, I again redo laparoscopy, histoscopy on them. And then depending on what finding I find, if the tubes are open and endometrium is fine, then the patient can try normal ovulation or ovulation induction drugs. If tubes are blocked and endometrium is fine, they can go for IVF-PT. If tubes are blocked, endometrium adhesion, we can break them. But the adhesion is grade 4, 5, which we can't break, then the patient goes for surrogacy. Okay, because her ovaries are fine. Sometimes even ovaries are gone. So endometrium is gone and tubes are blocked and even ovaries are gone, then we can even do, like the patient can go for adoption. Next slide, please. Yeah. Okay. So assisted ART has good role after giving good ATT. Don't do, I mean, when the patient is taking ATT, don't do IVF-PT at that time because ATT will increase the submucosal blood flow, endometrium thickness and all. So chances of implantation failure will be less after ATT. If during tuberculosis you try to do IVF-PT, implantation failure will be high, abortion rate is high, preterm delivery is high, IUD is high. So it's better to give treatment and then only start the treatment. But rarely, if the patient is already 35 years old or so, then you can, after RHZD 2 months, then you can start the treatment. I mean, in the continuation phase. And no need of use of condom, etc. Patient can conceive. If they conceive on ATT, all the 4 drugs are safe in pregnancy. So the patient, still you have to continue ATT because to prevent abortion and other conditions. Yeah. So I'm almost finished that. Yeah. So this is that's the last algorithm. So same thing, whenever patient comes to me suspicious of that, so I tend to do like, endometrial sampling on her. If the on endometrial sample EA positive for ARB, microscopy, culture, gene expert or histopath, she definitely TB, no need of any further test, give her ATT. If only PCR positive or other suspicious this thing, then I do, or on ultrasound and all, there is a TO mass. PCR with TO mass on ultrasound, again, probable TB, you can start ATT. Otherwise, I do laparoscopy on them. So only PCR positive, other tests are negative, or I'm suspicious of TB, then I do laparoscopy, histoscopy on them, and I showed the signs already. So definite sign, definite TB, start ATT. Probable sign, probable TB, start ATT. And after 6 months of ATT, I repeat laparoscopy, histoscopy, and depending on the finding, I advise the patient further treatment in the form of ovulation induction, IVF-PT, or surrogacy or adoption. Thank you very much.
Thank you so much, sir. It was really a wonderful talk, and especially your USG findings. I think one should be very aware how because it can at times be confused with findings of endometriosis also.
Yeah, absolutely.
Monica, ma'am, your comments, please.
I'm listening to this talk, Dr. Sharma's talk, after almost a year, and there are so many new things. And I'm really honored to have you in the program, sir. And thank you so much, because there was so much of confusion in a few webinars which I attended. Then I quoted your talk and I quoted your paper.
Thank you.
So, sir, I just wanted to ask, is there some difference between the Government of India guidelines and the guidelines which you say in the composite reference standard? Is there any difference in the two guidelines,
Yeah,
sir?
madam, actually the government doesn't, they don't want us to do PCR at all. Government only wants, like, AFB microscopy, AFB culture, gene expert they allow, and histopath they allow. So they only that they want, because actually government doesn't want to give ATT for genital TB. For them, priority remains pulmonary TB. So what we have negotiated with them that, so they don't want PCR to be done actually. But we are using PCR not as a treatment. I mean, we don't start treatment on the basis of PCR, but many infertility experts do. So I use PCR as a method of screening tool, and then I do laparoscopy, histoscopy on them. So if in your practice, madam, you feel that this patient has got tuberculosis, many times we feel she has TB. In that case, I do a laparoscopy, histoscopy or not, and even on subtle signs you can mention that there is laparoscopic evidence of TB, and then ATT is recommended. So then you are justified in court of law also, and nobody can penalize you for that. But you document it. But only PCR, then they don't allow. So I'm using PCR as a screening tool to do laparoscopy, histoscopy, and on laparoscopy there will be some finding in such patients, and then on that basis you can start ATT.
So, sir,
But if
one
on
of
PCR positive, but laparoscopy totally normal, histoscopy totally normal, then we don't start ATT.
okay, sir, then somebody was commenting amongst the audience that Gene Expert is actually advanced form of PCR only.
No, that is true, madam. But like Gene Expert is a higher form of a PCR, but that its accuracy is very, very high. Specificity is almost 100%. But PCR actually, what happens? Gene Expert is a standardized tool from all over the world. It can't be wrong. But PCR actually that PCR depends on lab to lab. So its sensitivity, specificity varies from lab to lab, and quality standard is also not maintained. So that's why PCR cannot be relied upon to that extent as Gene Expert.
Thank you,
So
sir.
the Gene Expert is a type of PCR, but it's highly standardized PCR international level, and same quality is maintained. So that is as good as AFB microscopy.
Yes, sir. Thank you so much, sir. Thank you.
Thank
That clears so much of the
Thank you, sir,
confusion.
and thank you, Monica ma'am, and wish you all the best for the forthcoming election.
Yes,
and
Dr.
I'm
Monica,
sure you're going
absolutely.
to
We
rock.
are totally with you.
Thank you, sir. Thank you so
Okay,
much.
thank you again. A pleasure, man, and best of luck. And thank you, Dr. Manoj. Nice to meet you. Okay,
Many
thank you.
thanks, sir.
Thank
So, Dr. Purva,
Did
can
you-
you start session 2? Dr. Banker has joined us.
Yes, ma'am.
Good evening, Manish, sir.
Good evening.
Greetings from Symbiosis, sir. And it's a pleasure to have you again. Sir was with us in Perfection, and now sir is with us in Symbiosis with another great talk.
Now moving forward for session 2, we have Dr. Manish Banker, sir, speaking on how can we improve our IVF results. To chair the session, we have Dr. Lalita Bajaj, ma'am, and Dr. Shri Revati Sadashivam, ma'am. Dr. Lalita Bajaj, ma'am, she is presently President Aurangabad OBGY Society. She has held various executive posts in Aurangabad OBGY Society, like Secretary, Vice President, and Cultural Secretary. She is working in prestigious hospitals of Mumbai, and her area of interest is high-risk obstetrics. We welcome you, ma'am, to chair the session. Next, we have with us Dr. Shri Revati Sadashivam. Madam is presently President, Erode OBGY Society. She is currently practicing as fertility consultant at Genesis IVF, underwent fertility training at County Hospital, UK, worked as registrar in the County Hospital, UK. She has also underwent clinical embryology training in Monash University. And she is presently EC member of infertility IFS chapter Tamil Nadu, and she has been awarded with Best Paper Award in British Fertility Forum meet. Her special interest is infertility, reproductive endocrinology, and embryology. We welcome you, ma'am. Now I hand over the session to chairperson to introduce our speaker, sir, Dr. Manish Banker, sir.
Good evening, one and all. Shall I introduce Dr. Manish Bankar, sir?
Yes, ma'am.
I am audible. Yes, yes. At the onset, I want to thank you, Dr. Monica, madam, for making me the chairperson. I am very happy to be the part of this webinar with the giant personalities. All the very best, Dr. Monica, madam, for your upcoming election. Now our speaker for the talk is Dr. Manish Bankar, sir. He is a director of Bankar IVF and Women's Hospital. He has been awarded with the VC Roy Award by the Medical Council of India for year 2017. He is a past president of Indian Society of Assisted Reproduction ISAR in 2012 to 2014. He is a regional representative of International Committee of Monitoring ART. Senior Associate Editor for the Journal of Human Reproductive Science, JHRS. He is a member of Board of Director of Poseidon Group, member of Surveillance Editor, Board of IFFS in 2011, 14, 17, and 2020. He is a member of Board of Directors of Pacific Rim Society of Reproductive Medicine, PSRM, and a founder board member of ASPRE, Asian Pacific Initiative on Reproductive Endocrinology. He is a member and draft committee of ART Bill of India at ICMR, Ministry of Health, India. I welcome Dr. Manish Bankar sir for your talk. Sir will be giving talk on how can we improve our IVF results.
Thank you very much for the introduction, and also to Dr. Monica for inviting me to be a part of this highly successful web series. So what I shall be talking over the next 20-25 minutes is how do you optimize your success rates in IVF. But before that, we should actually have a few minutes to see what does actually success mean when we talk in terms of IVF success. Because from a couple's perspective, when they come to you for treatment, what they want is to have a healthy child. And what they have in their mind is that if they introduce the procedure of IVF, all of them will have a healthy child as the desired outcome. But what the couple doesn't know is that in this journey of the entire IVF procedure, there could be many unforeseen events. And of course, no medical procedure can be 100% safe. So we need to also have certain safety issues with the procedures. So these unforeseen events begin from cancellation of the cycle because the response is not poor, or when all the oocytes fail to fertilize, or no embryos are formed, the embryo does not implant, or it leads to a miscarriage, or there is a congenital malformation, or there is a perinatal complication. So like any other pregnancy, even the IVF procedure can have any of these unforeseen and undesired events in the entire process. In addition to this, we are also worried about two major complications. One is related to ovarian stimulation. On the one extreme, you could have an extremely poor response, or on the other extreme, you could have an excessive response leading to hyperstimulation syndrome and the potential risks associated with the ovum pickup procedure in terms of mechanical injuries or because of anesthesia. So even though from a patient's perspective, it is a journey from not having a child to a healthy child, there could be a lot of unforeseen events and possible complications in this entire journey. So keeping this in mind, then how do we define the success? And when we look at the success ratio, it should have a denominator and a numerator. When we look at IVF success, there are many potential numerators, from a positive beta HCG test to a clinical pregnancy to an ongoing pregnancy to a live birth. And from the denominators, it could be per woman, per cycle started, per egg retrieval, per embryo transfer. Now you must be wondering, does this really matter? It does actually, because depending on how you define it, you could have different answers. So let me share with you this single scenario. Let's say about 105 patients start ovarian stimulation. Generally, around 4 or 5% of these cycles get cancelled. So out of this 100 patient, 105, 100 end up with an egg pickup. 90% of them will have an embryo to be transferred. 50% of this would become pregnant. 40% would continue the pregnancy without having a biochemical or a clinical abortion, and maybe around 30% would end up with a live birth. So depending on how you define this, so if you look at pregnancy rate per embryo transfer, it will show you the highest percentage of 50 upon 90, which is 55.5%. But the moment you go to the next level and you start defining it as per OPU, this drops to 50%. If you look at a clinical pregnancy from a positive beta HCG, this will further drop to 44%. And if you look at the live birth, it would further drop to 27.7%. And if you look at this from per pickup, it is 25%. And if you look at it per patient, it is 23.8%. So the same case scenario, you could claim that my pregnancy rate is 55.5% per embryo transfer that I do, but from the patient's perspective, she has a 24% chance of having a live birth using the same data. So this is the first thing which is very important when we look at defining the success. The second issue is about the embryo implantation. And let me give you another example. Let's say there are two clinics A and B. Both have a pregnancy rate of 50%, which means if 100 patients start treatment at this center, 50 would become pregnant. Are they both equally good? Let us look at some more data. So Clinic A transfers 2 embryos in all the 100 patients. So it transfers 200 embryos and to achieve 50 pregnancies. Whereas Center B transfers on an average 1.5 embryo per transfer, which means it does 50% single embryo transfer. So this clinic utilizes only 150 embryos to make the same 50 patients become pregnant. So obviously, even though the pregnancy rates are the same, Center B is a much better clinic because it will have additional 50 embryos left. And if we use the pregnancy rate of 25%, it will give pregnancy to another 25 patients from these 50 embryos. So defining and describing pregnancy is not as simple as it seems. And the first question that should be asked when anyone talks about pregnancy rates is, what are you actually talking about? And if there is so much confusion, then how does the world report success? You cannot have the world reporting success in different numerators or denominators. And let us see what the world does. Now, HFEA defines success as birth rate per cycle started, because this is what is the most important figure from a patient's perspective. So the percentage of cycles that were started in 1 year that resulted in a live birth. And if you look at the previous table which I showed, this is somewhere around 23-24% as opposed to the 55% which was per ET. However, the pregnancy rate per embryo transfer is actually used when we want to compare different data for internal quality control. What is the outcome when you transfer single embryo versus double embryo? What is the outcome if you transfer a blastocyst versus a cleavage stage embryo, etc. But from a success point of view, it is live birth from initiated cycles. Similarly, the SART database, which is the US database, which defines that a cycle is counted when a woman starts her medication and delivery of a child is the outcome of interest. So from all the women who start a cycle, how many of them have a live birth is the way success is defined. It also goes one step further and defines that it is the singleton delivery which is the preferred outcome because twins have higher complications. So the world defines success as cumulative singleton live birth per cycle initiated. And we should all be talking the same language when we are counseling our patients so that the message that goes to the patient is similar and it is in sync with what the patient wants. Before going into how do we achieve this, let us see what are the major risks in this procedure. Because the first thing that we need to do is avoid any complications. And the 4 major risks of the IVF procedure are ovarian hyperstimulation syndrome, multiple pregnancies, maternal and perinatal morbidity and mortality, and congenital abnormality. And let us see about these 4 indications. Now, OHSS is essentially purely iatrogenic. In the early days, it was reported in around 33% of the patients having mild and maybe around 2% having severe requiring hospitalization. We then had the concept of segmentation of IVF cycles. So all patients who were at risk of ovarian hyperstimulation syndrome received the agonist trigger antagonist protocol, and the concept of OHSS free clinic came in, and OHSS became practically absent. But the risk is still there. We can never 100% eliminate ovarian hyperstimulation syndrome. We have 2 publications reporting severe ovarian hyperstimulation syndrome in spite of the agonist trigger and the all-freeze approach. So this is something which has been significantly reduced, but it can still happen. The second major issue is that of multiple pregnancies, and this is a very large study. 1 crore 70 lakh pregnant women, very large study. And this shows that the twinning rate is 32% compared to 1.5% in the non-IVF group. So IVF increases the risks of twin pregnancies multiple fold. We also know that this multiple pregnancies have various potential complications because multiple births have higher morbidity and mortality, and hence the success needs to be redefined, and we should be starting to talk in terms of singleton live births, and most professional bodies are now recommending elective single embryo transfer of a blastocyst in all young women. We have shown that this is something which is even possible in our own setting, because if we do 2 elective single embryo transfers, that is, if the patient has 2 blastocysts, rather than putting both the blastocysts in one go, if you put one in the first transfer, and if she fails, you put the second blastocyst in the second transfer, then the cumulative live birth rate was higher when you did 2 elective single embryo transfers, one after the other, versus 1 double embryo transfer. And this is what we eventually want. We want healthy live birth, not a simple pregnancy. Because the overall risks of a twin pregnancy, both to the mother and the child, are significantly higher. For the mother, there is a higher incidence of preeclampsia, gestational diabetes, preterm delivery, increased operative delivery, and a new terminology, that of parenting stress, because today bringing up 2 children is a major stress issue, and a large number of, or an increasing number of patients want elective single embryo transfer because they simply do not want a twin pregnancy. A twin pregnancy also carries higher neonatal risks because of prematurity, low birth weight, higher incidence of respiratory distress syndrome, and even the risk of cerebral palsy increases 3 times in twin pregnancies versus single pregnancy. So there are major maternal and neonatal risks associated with multiple pregnancy. And these risks are independent of the mother's age. So it is not that young mothers will not have the risk. The risk is higher across all the eggs, and hence elective single embryo transfer strategy is required, at least in the good prognosis patients. What about birth defects then? We have shown that the incidence of birth defects in IVF cycles, whether it is with self oocytes or with donor oocytes, is not higher than those in natural conceptions. So both self oocyte cycle as well as donor oocyte cycles do not carry a risk of higher congenital abnormalities. So then the question is, how do we achieve this high success rate? And the first question that comes to everyone's mind is, how many oocytes should we be aiming for? 5, 10, 15, 20? What is the ideal number of oocytes when we initiate ovarian stimulation for a patient? The question is there an optimal number of oocytes at which the live birth rate would plateau down, or would it maximize? 2 important takeaways from this message. Most studies show that if you look at outcomes based on the first fresh embryo transfer, the optimal number of oocytes is 12 to 18. And this is very logical, because if you have higher number of oocytes, and if you're looking at outcomes of the first fresh embryo transfer only, the additional oocytes are not going to improve this, because the additional oocytes only give additional embryos. But if you look at the cumulative live birth rate arising from that cycle, then with an increasing number of oocytes retrieved, there is an increase in the cumulative live birth rate. And this is how the world defines success now. Cumulative live birth rate from a single cycle. So higher the number of oocytes, higher the number of embryos available for transfer, higher the attempts at embryo transfer you can carry out, and higher the cumulative live birth rate. So this 12 to 15 oocyte is okay if you are looking at only the first embryo transfer. But when we're looking at cumulative live birth rate, you should aim to get the best possible number of oocytes. The question then that comes to mind is that does a higher dose or higher oocyte lead to worse quality? Are we only increasing the quantity? Does the oocyte quality deteriorate? And this study shows that in patients both below 35 and above 35 years, the aneuploidy rates do not increase if the gonadotrophin dose is higher. So the gonadotrophin dose or higher doses do not result in more abnormal oocytes. If we look at the live birth rate, this is also the same independent of the dose. So neither does the aneuploidy or the quality of the eggs increase with the or deteriorate with the gonadotrophin dose. However, higher the number of oocytes that you get, there is a higher probability that at least one of these embryos would be euploid, because all embryos are not normal. And if you have higher number of eggs resulting in higher number of embryos, you will have higher euploid embryos giving rise to better live births. So more the number of oocytes that you receive, higher will be the cumulative live birth rate. The fresh transfer rates might plateau down, but the cumulative live birth rates will keep on increasing with the number of oocytes that you are able to retrieve. So to achieve this higher number of oocytes, what would you do? What kind of stimulation will you use? And would you do a fresh or a frozen embryo transfer? Should the intensity of the stimulation be mild, moderate, or intense? And should you use the agonist downregulation or the antagonist protocol? If you compare the agonist versus the antagonist, there are two advantages of the antagonist. One is that the treatment period is shorter because the agonist will require suppression from the luteal phase of the previous cycle. Here, the treatment can be started from the second day. And second, it has the ability of giving the agonist trigger and thereby significantly reducing the risk of ovarian hyperstimulation syndrome. But in terms of outcomes, obstetrics and perinatal, both are similar. So this is, what we have is the third way of doing, rather than the agonist and the antagonist, we have the progesterone prime ovarian stimulation. Again, this has similar pregnancy outcomes, but is cheaper as compared to the antagonist, and you could still give the agonist trigger. Which type of embryo transfer then would you do, the fresh or the frozen embryo transfer? There were two papers in the New England Journal of Medicine in 2018, which looked at fresh versus frozen embryo transfer in women without polycystic ovarian syndrome and in ovulatory women. Because in patients at risk of OHSS, there is no doubt that you need to do an all freeze. But even if the patient does not have PCOS, both the papers showed that the pregnancy rates are similar in the fresh and the all freeze cycles. This was another large multicenter randomized controlled trial looking at a fresh single blastocyst transfer. Again, this showed that the pregnancy rate in the frozen embryo group was significantly higher as opposed to the fresh embryo transfer group. So this debate is still ongoing as to whether we should restrict all freeze only to those patients who are at high risk of hyperstimulation or who have a poor endometrium or who require PGT, etc., or should it be given to all patients? There were some concerns that doing an all-freeze cycle leads to a higher incidence of macrosomia and large for gestational age babies. But if all the studies were examined, only one of the studies looked at both the length and the head circumference in addition to the birth weight, and they found that these were not different in the frozen embryo transfer group, and all the other neonatal outcomes were similar. We then move on to when do we use technology to improve the pregnancy rates, or what other technologies are available to us to optimize the pregnancy rates. Maybe not for all patients, but in selected patients. From the endometrial receptivity perspective, we have different tests to look at the endometrial receptivity. And this systematic review and meta-analysis from 2023 shows that in women without recurrent implantation failure, that is in the unselected population, the live birth rates are not improved by carrying out endometrial receptivity studies. However, in patients who have recurrent implantation failure, doing a personalized embryo transfer guided by the receptivity analysis might improve the clinical pregnancy rate. And this is exactly the same what we have also shown in our publication. We studied 250 patients with recurrent implantation failure, having more than 4 failed embryo transfer cycles. And what we showed that in patients where the endometrium was found to be non-receptive, which means the embryo transfer had to be done after 4 or 6 days of progesterone, that is, a blastocyst transferred 1 day earlier or 1 day later than what one usually would have done, we can improve the pregnancy rates and bring them to the normal rates. So this is one option for a selected number of patients with recurrent implantation failure. The second technology that you have is to look at the aneuploidy, euploidy status of the embryos, called pre-implantation genetic testing for aneuploidy. Again, the systematic review and meta-analysis shows that it does not improve the live birth rate per patient in the general population. And this is again important to understand that if you're looking at outcomes per patient, this technology cannot improve the outcome, because even if you don't do the test, you will eventually transfer all the embryos available to you. It is only a matter of time. So what PGTA can potentially do is improve the outcomes per embryo transfer and thereby shorten the time to achieving a pregnancy. And second, it can reduce the it can lower the risk of miscarriage because you are not transferring aneuploid embryos. And this was significantly more apparent in women who are above the age of 35. And this also helps you in doing single embryo transfers opposed to untested 2 embryos. So the benefits of this are you can reduce the number of embryos that you transfer, lowers the miscarriage. It shortens the time to pregnancy by avoiding transfer of embryos which could be potentially aneuploid. But to achieve all this, we must look at the IVF lab, because I believe 70% of the contribution to the success of IVF comes from the IVF lab. How good is your lab in creating consistently good quality embryos? Because the IVF lab is a highly complex structure, you can see so many procedures happen in the lab, from media setup to pickup, denudation, FIRD check, embryo transfer, so on and so forth. A host of andrology procedures. It has a lot of equipments which require a lot of quality control measures, like measuring temperature, CO2, pH, VOCs, etc. And you need a lot of quality assurance mechanisms like SOPs, data analysis, benchmarking, etc. So as opposed to the ovarian stimulation pickup and the procedure of embryo transfer and luteal support, the lab performs a far higher number of complex procedures. It is also important to remember that outside of the lab, the most crucial factor or the factor which gives the greatest variability is the patient characteristic. But within the lab, all other parameters should be constant, because in the lab, if one step is not done properly, it will lower the success rate of that procedure, and no matter what you do later on, you will never be able to compensate for it. So you are as strong as your weakest link, and the weakest link in the IVF procedure many a times is the IVF lab. So let us see what are the options within the lab. First is the temperature in the incubators. You can see the results of a clinic which showed an unexpected dip in the month of June and July. And when they started looking at the temperature logs, it was found that the thermostat of the heating stage on which ICSI is carried out had malfunction. So very small apparent thing, the heating stage malfunctioning just when ICSI is doing, and this results in a significant drop in the pregnancy rate. You have numerous incubators available with you, but one thing will always be common in all the incubators, that you need to open the door to remove your dishes and to do the checks. Studies shown that if you open the door once every 15 minutes, that means once the door is opened, you do not open the door for the next 15 minutes, the incubator will have time to recover, because that is the minimum recovery time. But if you are putting or if you're culturing multiple patients in one incubator, or for your egg pickups, you're doing multiple egg pickups and you have only one incubator, and if you open the door within 15 minutes or very frequently, the incubator will not be able to maintain the temperature and culture conditions. And this will lead to permanent damage to the gametes or embryos that are being cultured in that incubator. So you must have sufficient number of incubators so that you do not open the incubator doors more frequently. The ICSI dish in which you carry out ICSI. Very simple studies that if you use a 5 microgram droplet with a 3 or 5 ml of oil, it does not provide adequate temperature protection. But if you use a bigger droplet, a bigger dish, and higher amount of oil, it will give you more protection. Because the most vulnerable part of the entire system is the oocyte, because oocyte is the largest cell in the body. It has the highest water content. And sometimes if your blastulation rates are poorer, maybe your handling of the oocyte was not good, and that has led to permanent but unseen damage to the oocytes, and hence leading to poor quality blastulation. We should also look at the VOCs. You should check them periodically. You should look at the quality of your suppliers, whether all the equipments and the disposables that you receive are adequately tested. And if possible, you should try to move to complete blastocyst, because this is the only way for selecting the best number of embryos. Because ideally, the uterus is prepared or is ready to accept a blastocyst only. In a natural conception, the cleavage up to the blastocyst happens in the fallopian tube, and it is only the blastocyst that enters the uterus through the tubal ostium. The endometrium is more synchronous and the uterus is more quieter. But you need optimal conditions to move to 100% blastocyst program in terms of incubators, because all your embryos will remain in the incubator for 2 extra days. So you will need those many extra incubators. This incubator should not be open. So if not one incubator per patient, at least one chamber per patient, you should have an optimized vitrification system, and you need to then transfer electively single embryo transfers. So there are numerous things that lead up to the success of IVF. It begins with how you want to define success in your patients, and then you follow all these steps, and you hope to give the best possible outcome to your patients. Once again, I thank Dr. Monica and the organizers for giving me this opportunity. Thank you very much.
Thank you, sir. Thank you so much. That was a very clear and insightful presentation. And it is always a great pleasure and a honor to listen to you. Thank you, Monica ma'am, for arranging Manisha's session on how to improve IVF lab results. That was a 360-degree approach right from the start of patient selection till the laboratory QA QC session. And hearty wishes to Monica ma'am for a grand victory.
Thank you, Dr. Revati, and thank you, Manish, sir. The best thing is when sir tells us how to calculate the success rate of a center. That is very important, the way it is advertised or way it is projected to the public. And because I think in India, patients don't know that much. So it is very important to be honest about your results. Only then we can reach that, benchmark which countries like Sweden and have reached. So thank you so much, Dr. Manish, sir. It was brilliant, and we are really, really blessed to have listened to you yet again. Thank you so much.
Always a pleasure. Thank
Thank
you.
you. Thank you so much, sir. Thank you. We can now start the third session.
Yes.
Lalita ma'am, ma'am, are you there for the?
Yes, ma'am.
Ma'am, please,
Yes.
could you chair the third session also?
Okay, madam.
Yes. Thank you so much, ma'am. Thank you.
Good evening, one and all. Third session is by Dr. Nitish Modia, sir. And sir is going to enlighten us on a very important topic of ART law in 2024. Are the rules being followed or flouted? To chair the session, I would like to invite very eminent chairperson, Dr. Lalita Bajaj, madam, and our own convener, Dr. Monica Singh, ma'am. Can we have CV of Lalita, madam? Lalita, ma'am, is the
It is all. Hi, it has been. No need to read it again. Yes,
but we welcome you again, ma'am. It's a pleasure to have
Thank
you.
you. Yes.
And I would like to speak few words about our own convener, ma'am, Dr. Monica Singh, ma'am. Please show her CV. Madam is a consultant of reproductive medicine and she is also a professor of LN Medical College.
Nandini, it's okay. Nandini, it's okay. Let us proceed.
Yes,
and
ma'am.
Lalita ma'am can introduce our esteemed speaker, Dr. Nitish Modia.
Okay, madam.
Who has joined.
Thank you, ma'am.
Dr. Vishal, can we have CV of Dr. Nitish, sir, please?
Nitish Murdia. Now, the next speaker for today's webinar is Dr. Nitish Muradia. He's an expert member of National Assisted Reproductive and Surrogacy Board. Amongst the many awards, he has won one of the prestigious one in Budding the Embryologist of Year National Gold by ET Health World National Fertility Award in 2019. Leading team of 160 plus embryologists setting the educational program for national and international candidates, implementing accreditation program and striving for the clinical excellence. He has hold a strong background in the management and SOP driven system, designed training for the Indira Fertility Academy, which have trained over 350 embryology and andrology candidates till now. Special interest is in artificial intelligence and new technology innovation, quality management system, and digitalization in the IVF lab. He has brought an exceptional technological advancement in the Indira IVF with the help of electronic witnessing, automated alarm and cloud monitoring system, and QMS dashboard. We are also having Indira IVF Center at Aurangabad also. So I'm very happy to introduce Dr. Nitish Mudaria. Now over to you, sir. Start with your talk.
Yeah, thank you, Lalita ma'am, for such a nice introduction, and thank you, Dr. Monica, for inviting me and giving me this opportunity. I will just project my screen.
I must thank you, Dr. Nitish. Despite your busy schedule, you always, say yes to our programs, to every program, and always so helpful. It solves everyone's problems regarding ART. You are really, you are a very, very good human being besides a good doctor. Thank you so much, Dr. Nitish, for joining.
Sharing my screen. Yeah, I hope.
Yes, yes, the screen is visible, Dr. Nitish.
Okay, right.
And I've seen that you have followed the title also, the same title which we gave you.
Yeah,
Thank you so much.
yeah, sure. All right. Just wanted to have a disclaimer that the views expressed are of my own. Okay, so let us look at what is the number of embryologists that we have in the country. We have gynecologists. We have close to around 45,000 gynecologists in the country. There are approximately 2,500 level 2 clinics, and the number of clinics who have applied for level 1 is somewhere around 3,200, which is dividing 5713, sorry, subtracting 2,500 from 5713, so which comes to 3,200 clinics which have applied for level 1. Now, the question to ask here is that there are almost 45,000 gynecologists in the country, and only 3,200 level 1 clinics have been applied till now. So, is it that there are a lot of gynecologists who are doing IUIs without having a level 1 registration is something which, is a big, question to ask. So I think this is the screenshot that you see on the right hand side. This has been taken today morning at 10 o'clock, which clearly says that there are 5713 ART clinics who have registered for ART level 1 and level 2. There are almost close to 15, 17 ART banks who have registered for the bank, and there are close to 1023 surrogacy clinics who have registered for the surrogacy clinics. In terms of who have been approved, it normally takes a bit of time for the state to give the information to the central portal. So that is why there is some amount of delay, which is there here. Okay, let us look at why it is so important to register. There is, before the act, there was no offenses and penalty, but now because there is an act in place, and hence there is offenses and penalty. And the offense and penalty, if you see towards the end, which is indicated in the red box, you can clearly see that there is, for the first contravention, there is 5 to 10 lakhs of penalty. And for the second contravention, if it is repeated, then can be an imprisonment of 3 to 8 years with penalty ranging from 10 to 25 lakhs. Who is actually responsible and who can be punished? It is actually the ART clinic who can be punished. And also, it is the executive head of the ART clinic, which will be liable and responsible for such kind of punishment. And if the court feels that there is officer involved other than the executive head of the clinic, even they are liable to be punished. Let us look at few of the notifications which came after the act and what are the changes that has happened after the act came into place. So the first and foremost was there was a notification which came which allowed clinics to retrieve all the oocytes, especially from the donors, because the ART law said that not more than 7 oocytes can be retrieved from the donor, which was slightly modified with saying that provided that the clinic shall retrieve all formed follicles. So that means all the formed follicles of a donor has to be retrieved. Now there is a lot of confusion between states, cities, even doctors and the state authority, saying that you can only use, let's say if you retrieve 10 follicles or 10 eggs, you can only use 7 eggs and freeze the rest. And some people have no clarity. Now the whole point of putting this particular clause of 7 was to safeguard the donor, or rather for the safety of the donor. Now, once the oocytes are retrieved, whether you fertilize all the oocytes or whether you fertilize 7 or more, it has no implications on the safety of the donor, right? So, this particular thing I'm going to write to the DHR to give a clarification um on on this particular topic to the state authorities that whatever follicles have been retrieved should actually be used to fertilize or to freeze as per the clinical protocols, rather than restricting the clinics by the state authorities to only use it. There was one more addition where the endologist qualification, there are more members who have been included in the endologist, and there's a minimum experience which is put on the experience and the amount of surgical retrievals they have been doing. So this is again a notification which came on the 11th of July 2023. The recent one which came was on the surrogacy, where there was a donor. One of the gametes can be of the donor if the district medical board feels so that this is a necessary condition or a necessary medical condition that the couple might require a donor gamete. When it comes to single women, they cannot have they cannot avail donor eggs. They will have to use their own self eggs with donor sperms. Now let us understand the difference between ART level 1 and level 2 quickly. So level 1 clinics are the ones where IUI is carried out. Level 2 are the clinics where IUI and IVF both can be carried out. I have tried to put things here and there which are important for the clinics to maintain, and normally, a lot of clinics miss out on. So there is something written in the act which is called a grievance handling cell. There is a form number 5, which a patient or a legal representative or a family member or even an anonymous person can fill in, and any complaint they have against the clinic, this form should be kept at the reception. And the first level of complaint actually should be done at the clinic rather than reaching out to the state authority or the district authority for the same. The law does not define who can be a part of the grievance cell, but basically it can be a committee of a 2 to 3 member committee. And whatever complaint comes, the committee meets, decides of the action plan and inform the patient about it. There is a minimum staff requirement for a level 2, which is gynecologist, one anesthetist, one embryologist, one counselor. Director and andrologist are optional. Let us just put a bit of more emphasis on the counselor, why a counselor is required and why does the law says a counselor is required. So if you look at the clause 21, 22, it clearly says that you have to provide a professional counseling on the implication and chances of the success of ART. You have to inform advantages, disadvantages, cost, side effect, risk for arriving at an informed decision to the couple. You have to provide awareness on the rights of the child born through ART. You cannot perform any treatment or procedure without the written informed consent of all the parties seeking ART. The consent can be withdrawn anytime before the gamete transfer, and that is why the role of counselor becomes very, very important. The gynecologist, someone who has 3 years of experience with 50 ovum pickups, or if he or she has a fellowship in reproductive medicine, then 50 pickup experience is not required. She just needs 3 years of experience. Embryologist, again, there is a lot of qualifications which are put in. They are mainly classified into 4 categories, which is postgraduate in clinical embryology, a PhD, a medical graduate, which is MBBS or a veterinary graduate, and a postgraduate in life science. There is a different requirement in terms of the experience for all these four categories of embryologists. Andrologist, I have already covered. Counselor can be a psychologist, a clinical psychologist, a nursing or a life science graduate. A director can be a postgraduate in medical or life science of management science. Equipment, of course, there is a list. A lot of centers have already gone through the registration process, so I'll not cover the equipment part, but this is what is listed in the Act. Now, let's say a clinic gets established after the Act. What is important to be followed is that no person shall establish any clinic or bank for undertaking ART or to render ART technology procedures to in any form unless such clinic or bank is duly registered under the Act. Right, so there is a registration requirement, and you can only go for it after you are being registered. Existing clinics, I think, is being covered multiple times, so they can continue to act the way they are. There are a lot of states which have not still issued the registration, which is UP and Bihar and some more part of the state. But if you have applied for the registration, you cover that risk yourself, and you don't need to wait for it. There is strict eligibility criteria when it comes to age: female 21 to 50, male 21 to 55. Donor is now to be obtained from the banks. You cannot treat a woman with sperms derived from multiple men. You can never mix semen of two individuals. The storing has to be done properly. It has to be secure. There has to be a recording. There has to be identification. All unused gametes shall be used on the same recipient. You cannot donate, from one couple to a second couple. And the sale and transfer of the gamete is prohibited. And only if the couple wants to use the gamete and transfer the gamete within India or outside India, it requires a permission of the national board, which typically the whole process takes around 4 to 6 months. There is again restrictions on the duration. You can cryopreserve the embryo or the gametes. You cannot do it for more than 10 years. Especially in the oncofertility patient, if you're doing it for more than 10 years, you will have to seek a permission from the national board for this particular extension. One more change that has happened is the posthumously the gamete collection. You can only do it if you have a prior consent from the commissioning couple. Then only you can do a posthumous collection. Otherwise, you are not allowed to do that. When it comes to genetic testing, they will have to ensure that there is a already pre-implantation genetic testing shall be used to screen humans from known pre-existing heritable or genetic diseases or when medically indicated. The government has not defined what is medically indicated, but you can use your own, practice and sense and the literature to indicate when, PGT has to be used or when it is medically indicated. When it comes to the oocyte donor, the bank will be the one who will be responsible to determine the eligibility of the bank of the gamete donors. When it comes to female, the donors have to be between the age of 23 to 35. This is the only criteria. You should not worry about married, unmarried, having children, anonymous, non-anonymous. The only thing you should be concerned about is the age of the female donor, which is between 23 to 35. When it comes to the males donor, the age is between 21 to 55 years of age. These are the four tests which has to be done, which is HIV, hepatitis B, hepatitis C, and VDRL. The donors have to be minimum tested for these four tests. There can be extra tests done by the bank or by the clinic as per your desired protocols. What a bank has to store for the donor is the name, Aadhaar number, and the address. These are three important parameters which the bank has to store, and they have to be maintained confidential. The bank shall not supply sperm or oocyte of a single donor to more than one commissioning couple. So if you are using a donor once on a single commissioning couple, you cannot use the same donor on multiple commissioning couple. And again, the donor or the embryo cannot be stored for more than 10 years, which is just similar to what I have told you earlier. The only difference when it comes to a donor of male and female is that oocyte donor shall donate oocytes only once in a lifetime. Whereas when it comes to a semen donor, there is no such thing written in the act. So a semen donor can donate multiple times in their lifetime. But what we need to make sure is that it has to be used on the same commissioning couple. There is an insurance and affidavit which is required. Now, when it comes to insurance, make sure that you have two insurance taken for the donor. One is the health insurance, and second is the life insurance. The law does not say anything about the amount of the insurance, but you can keep it as required to cover the expenses. Normally or typically, a life insurance of 3 to 5 lakhs should cover the risk associated with the egg pickup, and a death insurance of 5 to 10 lakhs should be sufficient to cover, the death, uh, you know, um, insurance or settlement. And the intending couple will have to give affidavit, which is on the notarized stamp paper, that all the risk and all I give a guarantee to cover all the risk as per the section 22(4)(2) of the ART Act. There have been a lot of confusion also with in terms of if a foreign couple comes to India and if they require a donor gamete, can they get their own foreign donor or not? Now, if you look at the form number 13 and the form number 14B, both these forms have one typical thing, which is the Aadhaar card number, right? So when it comes to a foreign donor, foreign couple coming to India and using a donor, you can use an Indian donor on a foreign couple because you will need to fill in the Aadhaar card number here and also the here. Let us look at the information. So obviously the national registry is not yet established, but a lot of states have started asking to submit the details before the 5th of every month, similar to the PCPNDT Act, and a lot of clinics have started submitting this information. But when it comes to record keeping, you need to make sure that you keep the record for at least 10 years. If the clinic is closing before the 10 years time period, you will have to submit all the records to the National Registry. And if there's a court case proceeding against you, you will have to preserve it till the court case is disposed of. The search and seizure is similar to the PCPNDT Act. There can be a national board, a national registry, state board, or appropriate authority, or any officer authorized on this behalf can come to your clinic and do search and seizure activity if required. With this, I come to the end of my presentation. Thank you very much. If there is any questions, I'll be happy to take.
I want to ask, is there anything that injectable cannot be used by, if our center is not recognized for level 1 or level 2, the ovulation induction with the injectable drugs, can it be done with GnRH analogs, or there is some restriction on it, new rules?
See, ma'am, the whole point of making the act is actually to divide the practice, right? That let us classify patients into three different categories. One is a patient who are very early in their married life and they are trying to conceive and they are not able to conceive and they go to a gynecologist. They would probably be given a OI and TI with an oral medication, which is a very simpler case. Because of the oral medication, the risk of OHSs will be quite low and minimized. So that kind of category of the patient, obviously a level, you don't require a level 1 or level 2. A gynecologist can, do it themselves. But when they fail this kind of treatment and they require slightly higher treatment, maybe with injectables or IUI, right? Then they should actually be referred to a level 1 center where, in case if IUI is required with injectables, they can do a treatment at level 1. And then if they fail at a level 1 center and they probably require IVF treatment, then they should be referred to a level 2 center. So the whole thought process is actually to divide the practice into three different categorization. And that is why they have put certain restrictions on the equipment and the qualification of the doctors also between a level 1 and a level 2.
Okay. With the oral ovulation induction, if it doesn't respond, then we cannot use injectable for the, if we are not going for IUI or something like that. For IUI, we need registration of the clinic, na?
Yeah, I mean, see, again, the law is not very clear. And it's not saying that, this and
Because
this.
one
The
of
law
our
says
colleague
that,
was telling that you cannot use HCG also for the follicular rupture after ovulation induction without consent. New law is like that. One of our colleague was telling that you cannot use HCG injection also for the follicular rupture.
Yeah,
Is
so
it
so
something like
typically as per the act, it is level 1 IUI, level 2 IUI IVF, right? That is the right interpretation, right? But
okay.
you know, how ART authority behaves in your local thing is dependent on how they, they perceive the law or how good they are, when it comes to understanding the law, right? So, I mean, MP has been really good due to Dr. Randi, Dr. Monica. They have been engaging the authority to a certain level and they understand the act now. So, again, it depends on the understanding of the local authority, but it is better to play safe when it comes to you.
So there are a lot of gray areas, Dr. Nitish, still state-wise there are lots of problems. And I was worried because there was certain news of, donor just being recruited in some centers in Bhopal. Now, I don't know. This donor was just being recruited from a locality by an IVF center. So I was wondering whether they know the rules, whether they are aware of the rules and the punishment and everything. So I think a lot of states have to be given some responsibility to educate the IVF centers who are registered in that state, so that the owners and the directors and the clinicians of that center at least know what the rules are. Because very many of them are not attending these sessions, these conferences, and they are not reading the rules, and they don't know the implications of the ART Act. What I feel is that that is why a lot of confusion.
Yeah,
So
that's very true.
So I think you have to take a lead because Dr. Nitish, you have been instrumental with the center in delineating, and I see you every day answering questions of so many of the doctors. He is continuously answering, Dr. Nitish, whatever doubts are there. Some of the doubts are very simple, some of the doubts are more complicated. But I feel we have to follow, like in PCPNDT, we were so serious and we could make an improvement in the whole of India. There are always black sheep in every profession everywhere, but still if like PCPNDT, the ART Act is also followed to the T, then definitely it's going to make a lot of difference to our practice and it is going to give us a lot of good outcome. Thank you so much, Dr. Nitish. Thank you, Lalita ma'am, for chairing 2 sessions back to back for us.
It
And
was excellent talk by Dr.
Thank you.
Mr.
Thank you so
Nitish.
much.
It
Thank
was
you.
excellent talk. You have explained everything about the ART. Actually, there are many gray areas like Monica madam was telling. Now, government is also taking very good action regarding the proper because any person comes and they give us so many instruction regarding the laws. You should do this, you should not do this, you should not do this. But listening to you and attending such webinar, it keep us updating with the things. Very nice webinar. Thank you. Thank you very much.
And I feel my message to everyone is who is giving HCG or advising TI, doing OI with letrozole CC, why not go for level 1? It will make things more simple, more clear. You will come to know new rules. You will follow them. You can do IUI confidently. And IUI gives you 10, 15, 20% result. Why not do it?
Yes,
And then you will have the confidence one day to move to level 2.
Yes.
I think there should be no dilemma about it. If you are interested in infertility, go for level 1. Thank you
Yeah,
so
I
much.
think the ignorance is more, in the gynecologist because we see a very less number of level 1 centers being registered. And it seems like a lot of people are still doing IUI without a level 1 center, which
Yes.
is very dangerous. And, we need to pass this information through Foxy and through other medias to all the gynecologists that, as Dr. Monica said, level 1 is very easy to get. And, most of the gynecologists actually should get a level 1 registration.
Yes.
Yes.
I think we should, Foxy can start a, campaign, start level 1. So start level 1 can be like a campaign. So it will motivate everyone to join in, because there are many senior gynecologists of my city who are complaining that why aren't we able to do IUI? Because they
Right.
don't have those equipped setups, or they were just going here and there and doing IUI. IUI, people took it very lightly. People took IUI something like an ultrasound, go and get it done anywhere. But now even ultrasound, obstetric ultrasound is also difficult. So Dr. Nitish, thank you so much for clearing the cobwebs once again, for making the theme better for all of us. And I'm sure, I'm a very optimistic person, so I'm sure India is going to go in the right direction with leaders like Dr. Nitish.
Thank you.
Thank you.
Thank you so much.
Thank you.
so
Thank you very
much.
much.
And again, at the end of the session, I would like to thank Foxy. I would like to thank our 3 coordinators. I would like to thank Lalita ma'am. I would like to thank JB Sharma sir, Manish Bankar sir, Nitish Murdia. And of course, our technical support team with Intas Pharma, Dr. Vishal Dave, for always being there. And that brings us to the end of Best of Symbiosis Part 1. We will have another set of 3 lectures on the next Friday, that is 16th of August. Thank you so much. And have
Thank
a very
you.
thank you.
Thank you, ma'am. Thank you,
Thank
ma'am.
you. Thank you.
Thank you.
Thank
Bye.
you, ma'am. Thank
Bye.
you, ma'am.